Good afternoon. We're here at ASH with Dr. Rob Rifkin from Rocky Mountain Cancer Centers. Dr. Rifkin is also the myeloma research lead for US Oncology, as well as he has recently joined the World Myeloma Forum as an expert panel member. Welcome to the program. So we would like to have Dr. Rifkin provide an overview of kind of the key topics and key themes that have emerged from this busy ASH meeting, and wanted him to just touch on a number of these things that he envisions will have an impact on the future treatment of myeloma. Dr. Rifkin?
Well, thank you, Blake. I think this has been a very exciting ASH meeting, and changes in myeloma therapy have spanned the gamut, all the way from chemotherapy through the immuno-oncologics, and now most recently, tremendous amount of information here at ASH regarding CAR T-cell therapy in multiple myeloma. While the CAR T-cell data is very, very exciting, I think at this point, it's still a bit of proof of principle, and we'll really have to see long-term follow-up on the myeloma patients that receive the BCMA construct CAR T to see how it really works. Probably next down the line will be a late-breaking abstract tomorrow where Daratumumab was compared to a trial using VMP versus VMP Dara, and there's been a significant improvement in progression-free and probably overall survival soon. So that combination will reinforce data already known from the Pollux and Castor trials in the relapse refractory setting. I think what it will do is help to advance Daratumumab to the front line of myeloma therapy. And so the monoclonal antibodies will really become of age.
With regard to Daratumumab, they're also exploring new formulations where they're administering this large molecule through a subcutaneous injection. Have you heard anything about those data and how those data are matured and the advantages that brings to patient care?
So Daratumumab's always been an interesting monoclonal antibody, in that the way it was first released, there were significant issues with infusion reactions and length of infusion. So often the first infusion in your office could be somewhere on the order of 8 or more hours. In data we presented at this meeting, we split the dose of Dara into 8 milligrams per kilogram on days 1 and 2, changed some pre-medication regimens, and now have a very low incidence of infusion reactions. As everyone knows, Daratumumab will be formulated into a sub-Q package. Data on that was initially presented here at this ASH meeting as well, and looks very promising. Certainly the subcutaneous formulation will move forward in all of the ongoing and planned Daratumumab trials. So I think that'll be an interesting thing from a patient convenience standpoint. And then, of course, with all myeloma therapies, we'll have to begin to explore the economics, cost of care, and value-based care. And that would sort of lead me to, I think, the last important developments here at ASH, where if you went to the posters, all of a sudden the outcomes research here at ASH has become a giant part. Just a very few years ago, there were just scattered posters, and now there are tremendous numbers of posters exploring value-based care, patient-reported outcomes, and a whole host of things. In a couple of our presentations at this ASH, we looked at dosing of Carfilzomib to see if it was dosed per label versus not per label, and then to look and see what the impact was on patient outcomes. And we've shown that it's quite important to escalate the dose of Carfilzomib beyond the initial 20 milligram starting dose to get up to a full therapeutic dose, even as high as 45 or 56 milligrams per meter squared. And then finally, we'll await the results in that area of an ongoing phase 3 trial where once-weekly Carfilzomib is compared to the more conventional dosing schedule. So I think this ASH really spanned the gamut in myeloma. I think it's become relatively clear that just about everyone is getting maintenance therapy of some form. And now the importance of testing for minimal residual disease, because it's clearly been shown in a lot of the studies presented here that MRD negativity confers a survival advantage. And we'll truly have to figure out how to integrate that sort of testing into our community network.
So lots of very rich topics that are continuing to be explored and advanced at ASH, and thanks very much for that quick and succinct review. We'll look forward to further discussions on the website when we can introduce some of these topics and get greater thoughts and opinions from the panel members.
Well, thank you very much, Blake.
Thank you.